Is that on? Okay, it's good now.
You got it?
Okay.
This works.
It seemed like there was something not working. Okay. Oh yeah, totally. Okay, that seems better. Can Zoom folks hear me now? Awesome. Okay, now take 3. We're good. So welcome everyone to Psychiatry Grand Rounds and the Laura Mann Integrative Healthcare Lecture Series. Laura Mann was a home birth nurse midwife, serving our patients with compassion and love. When Laura was diagnosed with stage 4 breast cancer, she learned to thrive with a whole health approach. She was a visionary, and her illness inspired her to build the first center in the area devoted to promoting the benefits of integrative healthcare. The Laura Mann Center merged with UVM in 2015, and we honor Laura's legacy through the endowed Laura Mann Integrative Healthcare Lecture Series. In relation to that, there is an Osher open house today for Parents Weekend from 1 to 3 at 184 South Prospect for those who would like to join. As Julie said, I'm Erin Bingham. I'm a nurse practitioner, a family nurse practitioner at the Comprehensive Pain Program. I have the absolute honor of introducing Dr. Eric Garland today. I invited him here a year ago after being trained in his mindfulness-based protocol, Mindfulness-Oriented Recovery Enhancement, which I am now using in group medical visits because I believe so deeply in what Dr. Herbert Benson, a cardiologist at Harvard, said in his book, Relaxation Revolution, that mind-body science has now reached a stage where it should be accepted as the third major treatment and prevention option, standing as an equal alongside drugs and surgery in the clinical medical pantheon. Dr. Eric Garland is making this happen. Dr. Eric Garland is endowed professor in health sciences at the T. Denny Sanford Institute for Empathy and Compassion, professor in the Department of Psychiatry, School of Medicine, at the University of California, San Diego, and director of UCSD One Mind, optimized neuroscience-enhanced intervention design. Dr. Garland is the developer of an innovative mindfulness-based intervention founded on insights derived from cognitive, affective, and neurobiological science called Mindfulness-Oriented Recovery Enhancement, or MORE. He has published more than 260 scientific articles and has received more than $90 million in research grants from a variety of prestigious entities, including the National Institutes of Health, the Department of Defense, and the Patient-Centered Outcomes Research Institute to conduct biobehavioral clinical trials and develop and test novel integrative health interventions, including trials of MORE, as a treatment for addiction and chronic pain. In 2019, he was appointed by NIH Director Dr. Francis Collins to the NIH HEAL multidisciplinary working group comprised of national experts on pain and addiction research to help guide the nation's $2+ billion HEAL initiative to use science to halt the opioid crisis. Dr. Garland has briefed federal policymakers on MORE as a treatment to halt the opioid crisis. In 2023, Dr. Garland briefed the director of the White House Office of National Drug Control Policy. And in 2024, he was invited to the House of Representatives on Capitol Hill to brief the Congressional Addiction Treatment and Recovery Caucus. In a recent bibliographic analysis of mindfulness research published over the last 55 years, Dr. Garland was found to be the most prolific author on mindfulness research in the world. Thank you so much for being with us today. Please welcome Dr. Eric Garland. You're going to need this.
Thanks so much. First to Aaron for thinking of bringing me out here, and also to the amazing Osher Center here and the Department of Psychiatry for giving me this opportunity to come out and talk to you about my work. And you guys hear me? Okay, good. And as a personal sidebar, as a longtime fish fan, it's a true delight to be in Burlington since this is the mecca of all things fish. But I'm here to talk to you today about the intervention I developed called Mindfulness-Oriented Recovery Enhancement. So I have a disclosure. And so just to lay out some context for this talk, as we all know here in this room, addiction is a complex problem that is often driven by physical and emotional pain. For example, 50% of patients with an opioid use disorder have chronic pain, and over a third have a psychiatric disorder like depression or PTSD. And because of this complexity of issues, even with the current gold standard medical treatments for opioid use disorder, like methadone or Suboxone, 1 out of every 2 patients relapses within 6 months. So adjunctive approaches are needed to improve addiction outcomes, but there are few existing psychological treatments that can simultaneously address not only the addiction, but also the chronic pain and the emotion dysregulation that come along with this problem. So to fill this gap, I've spent the last 15 years working to develop one such intervention called Mindfulness-Oriented Recovery Enhancement. And that's what I'm here to talk to you about today. But to begin, in 2015, Nobel Prize-winning economists Case and Deaton found that for the first time in many decades, the US mortality rate was rising precipitously, to which they attributed in large part to the opioid crisis, a crisis that has been termed a disease of despair in the epidemiological literature. And the disease of despair has many sources, from the rising tide of income inequality to the lack of opportunity, to intergenerational violence and trauma, and the egocentric materialism and social isolation that's such a part of modern culture. And so in the face of this vacuum of meaning, it was perhaps inevitable that life would become more painful. And indeed it did. Rates of chronic pain soared in the US, where an estimated 50 million Americans experience chronic pain each year. So to alleviate this epidemic of pain, opioid prescriptions climbed. In 2015, 38% of the US adult population took an opioid that year. And this dramatic increase in opioid prescriptions was paralleled by a rising incidence of opioid misuse and opioid use disorder. And it's still a huge problem today. So latest prevalence estimates from the NISDA say that in 2022, 8.5 million Americans misused opioids and 6.5 million had an opioid use disorder. And of the 8.5 million Americans who misused opioids, 41% of them obtained the opioid from a healthcare provider. So that tells me that chronic pain is continuing to drive this crisis in part. You know, there's a lot of stuff in the media about the fentanyl crisis, illicit opioids from the street, and obviously fentanyl is killing a lot of people. But I think we can't forget that there's a major vector that still exists within the health system that is fueling this crisis. So I want to begin this talk with a clinical anecdote. A patient came to see me for help with chronic pain and opioid-related problems. He had received a series of 5 failed back surgeries, and after each one had been prescribed higher and higher doses of opioids. He knew he was taking too high of a dose. He knew he had a problem with opioids, but as he so poignantly stated to me, I just don't want to be in pain. I asked him a question that I ask many patients like this. I asked him to tell me about a time when he wasn't in so much pain, or maybe when his pain didn't really bother him at all. And he told me that on the weekends when his grandkids came over and he watched them play in the backyard, he became so focused and so absorbed in watching them play that it brought joy to his heart. And in that moment, he didn't notice his pain. His pain was temporarily gone. And so was his desire for opioids. And this clinical anecdote is probably familiar to those of you who work with patients like this, but I think it hints at a potential therapeutic mechanism that could be leveraged to help halt the opioid crisis. So to understand this claim, we need to understand the role that hedonic dysregulation plays in pain, pleasure, and addiction. Traditionally, in Western philosophy, pleasure and pain are considered opposites on a hedonic balance, such that increasing experiences of pain are thought to outweigh the experience of pleasure in everyday life. But modern neurobiology suggests that pleasure and pain are not mere opposites, but they actually operate through a common emotional currency in the brain, mediated by the mesocorticolimbic dopamine circuit and the endogenous opioid system. And these same brain systems that mediate the experience of pleasure and pain become hijacked by addictive drugs like opioids through an allostatic process in which chronic exposure to opioid use causes neuroplastic changes in corticolimbic and corticostriatal brain circuitry that increase sensitization to pain, stress, and drug-related cues, while decreasing sensitivity to the pleasure and meaning derived from naturally rewarding objects and events in the social environment. So in other words, as the individual becomes more and more dependent on opioids just to feel okay, they become less able to extract a natural, healthy sense of pleasure, joy, and meaning out of everyday life. And so that leaves them in a hole. They're scrambling to fill this hole. So they take higher and higher doses of the drug to preserve this dwindling sense of well-being, which ultimately leads to the downward spiral of loss of self-control over opioid use that's characteristic of addiction. But it's an interesting question. Well, actually, we should observe the fact that not everybody who's prescribed opioids becomes addicted to them or misuses them. In fact, most people don't. So it's an interesting question to consider. Why can some people take the opioid as prescribed by their healthcare provider, whereas other people go on and misuse the opioids or become addicted to them? So to answer this question, this has really been the focus of my basic clinical science research program. So we used tasks from cognitive neuroscience in my laboratory to answer the question. One of those tasks is the dot probe task. The dot probe task, there's a computer screen and it's split in two. On one side of the screen is a pain-related image. On the other side of the screen is a neutral image. These images are displayed for a very brief amount of time, about 1/5 of a second. It's just a flash. And then they disappear and a dot pops up. The participant's task is to choose the side with the dot. There's a large body of research to show that people with chronic pain are faster to find the dot when it replaces the pain image than when it replaces the neutral image. And this provides an objective indicator that their attention is hyperfixated on or biased towards pain-related information. We also pair neutral images and naturally rewarding positive images. And we pair opioid images and neutral images. And over a decade ago, my research group was the first to demonstrate that people with chronic pain who had an opioid use disorder were faster to find the dot when it replaced the opioid image than when it replaced the neutral image, indicating that they have an attentional bias towards opioid-related cues. And this opioid attentional bias significantly predicted opioid misuse 20 weeks following the end of treatment, suggesting that opioid misuse is linked with increased sensitivity to opioid-related cues. But in my lab, we also use another task to measure this hedonic dysregulatory process, and that task is called the emotion regulation task. So in the emotion regulation task, you show participants emotional images. In response to negative emotional images, they're asked either to view the image or to reappraise the image by reframing the meaning of the content of the image in such a way as to reduce its negative emotional impact. So to reappraise this image of this mother and child screaming in fear, one might think the mother and child faced the tragedy, but in facing the tragedy, it brought them closer together as a family. And thinking about the image in this way might make it less distressing. In response to positive emotional images like this father and son at the beach, participants are asked to either view the image or to savor the image by mindfully focusing their attention on what is pleasant, beautiful, and good in the image, and appreciating and amplifying any positive emotions or pleasurable body sensations arising during the savoring practice. And during this task, we measure an array of psychophysiological variables, including heart rate variability, which is the beat-to-beat variation in heart rate that is driven by the parasympathetic nervous system and governed by brain structures involved in regulating attention and emotion. So a number of years ago, my colleagues and I found that relative to patients who take opioids as prescribed, here depicted in the blue bars, opioid misusing chronic pain patients, depicted in the red bars, had significant blunting of high-frequency heart rate variability during reappraisal, viewing positive images, and savoring positive images. Which I'm going to use, see if it, uh-oh. Okay, good. I'm going to try to use my laser pointer for the people on Zoom. So this blunting of heart rate variability during reappraisal, viewing positive images, and savoring positive images indicated that these individuals have a selective deficit in the ability to shift their emotions in a positive direction. And we find converging evidence using EEG data. So here in blue, in the top center panel, these are brainwaves from patients who don't misuse opioids. These folks are able to decrease the brain's reactivity to negative emotional stimuli through reappraisal. They're able to calm down the brain's activity. See it here in the late positive potential. And beneath in red, these are brainwaves from patients who misuse opioids. Not only can they not reappraise effectively, but reappraisal actually backfires and amplifies the negative emotional brain reactivity. And then all the way on the right, we can see brainwaves during positive emotion regulation. In blue, these are brainwaves from patients who don't misuse opioids. These folks are able to increase their brain's activity from viewing positive images to savoring positive images. And in red, you can see brainwaves from patients with an opioid use disorder. So you see here total blunting of brain response during positive emotion regulation. And these deficits in negative emotion regulation and positive emotion regulation are associated with higher levels of opioid craving and predict opioid misuse in the future. So if this is the problem, this is part of the issue that's driving opioid misuse and addiction, that folks suffering from this issue have an inability to increase healthy positive emotions, then we really need to understand this mechanism and then address it with a treatment. And we have, more recently, we actually have used some fMRI to delve into the subcortical mechanisms of this deficit. And indeed, people with opioid use disorder do have corticostriatal deficits during reappraisal and savoring. So to address this problem, I developed mindfulness-oriented recovery enhancement, or MORE, which is an integrative mind-body therapy that unites complementary aspects of mindfulness training, cognitive behavioral therapy, and positive psychology into a structured treatment that can simultaneously address addictive behavior, emotional distress, and chronic pain. So before we move on and talk about MORE and the research behind it, I just want to lay out an operationalization for you about the construct of mindfulness. You know, mindfulness is everywhere these days. It's on magazines at the checkout stand in the supermarket, right? But I want to offer you a scientific operationalization of this construct. So in my view, mindfulness is a form of mental training that involves cultivating awareness and acceptance of your thoughts, emotions, body sensations, and perceptions in the present moment, and observing these mental contents as if you were a witness to your own experience. So there's this quality of meta-awareness that I think is really key to mindfulness. The practice of mindfulness is really simple. You start by focusing your attention on an object. It could be any object, but we often start teaching mindfulness by teaching people to focus on the sensation of the breath. And then after about 10 or 20 seconds, your mind starts to wander. And then all you do is you just notice that your mind has wandered off. And then you acknowledge and accept that thought or feeling. And then you let it go and come back to the object of mindfulness. So now you've done one loop of mindfulness. And I want to point out here that many patients and unfortunately, many providers, many people who teach mindfulness have a mistaken understanding of mindfulness. And they have this understanding that mindfulness is only step one. It's just attentional focus. But really, this entire loop is the loop of mindfulness. And it's very important because with each iteration of the loop, what you're really doing is you're activating the mind's capacity for meta-awareness, the awareness of awareness. People also often mistakenly construe mindfulness as a relaxation technique. It's not a relaxation technique. It does have profound effects on relaxation, but I would call those actually side effects. Mindfulness's real mechanism of action relates to attentional control, emotion regulation, and self-awareness that ultimately subserve self-regulation or self-control. I really think of mindfulness, especially in the context of addiction treatment, as a means of strengthening self-control. So more is a sequence treatment. It begins with the foundation of mindfulness training, which by virtue of strengthening attentional control and meta-awareness is used to synergize more elaborate therapeutic techniques like reappraisal and savoring, and ultimately to lead towards self-transcendence, the sense of being connected to something greater than the self. These treatment components are intended to activate a series of therapeutic mechanisms that are in turn intended to produce clinically significant change in treatment targets that are relevant to emotional pain, physical pain, and addictive behavior. And I would add here that more has been tested for a wide array of addictive behaviors, including addiction to opioids, alcohol, illicit drugs, smoking. We've studied more for obesity and even behavioral addictions like internet addiction. But the bulk of the research on more is around opioid misuse and addiction. And so that's what I'm going to focus on here today in this talk. So more is typically delivered as a group therapy. It's an 8-session group treatment. It can be delivered as an individual therapy, but so far we've mostly researched it as a group therapy. Group sessions are about 1.5 to 2 hours long. They begin with a formal mindfulness meditation practice, followed by a debrief and a group process, which is just exquisitely important for helping patients to consolidate what they've learned from the mindfulness practice, and then to apply that learning to addressing their symptoms in everyday life. After the group process, new psychoeducational material is delivered with the session topics listed here on the left. And then sessions end with an experiential exercise, some kind of mind-body practice designed to hammer home the concepts that you're trying to teach. Then participants are asked to practice homework consisting of 15 minutes of mindfulness, reappraisal, or savoring practice a day. Patients are also asked to stop and practice a couple of minutes of mindfulness before engaging in drug use. So I want to describe this technique to you. We call this the stop technique. This is one of the most simple techniques in the MORE program, but one that can be quite profound. So the technique involves first you stop right before you take opioids or other drugs. And then you take some time to practice mindful breathing. It doesn't have to be much. It could be 30 seconds. It could be a minute. And then next step is O, to observe your thoughts, feelings, and body sensations in this moment. So I want to paint a picture for you. So imagine that you are a patient with who's been taking opioids for a long time, and you're very physically dependent on the opioid, but you've also moved into opioid misuse, and you take OxyContin 3 times a day, and you're in between doses, and you're right coming up to the end of the period where you're going to take your next dose. So you're supposed to take it at 3, and it's 2:55, and you've got your pill bottle out, and you open up the lid, and you take the pill out, and you're bringing it to your mouth, and I tell you to stop. What are you going to be aware of in that moment? You're probably going to start to become mindful of feelings of irritation, impatience, tension, anxiety, craving. So doing this practice gives patients insights into what's driving the opioid use, and the patient can make a number of important observations that way, including observing that cravings change over time and fade away. That if you don't immediately give in to taking the pill, and you practice mindfulness in the context of it, that perhaps the desire for taking the opioid may decrease. You can observe that it's possible to have a craving, but you don't actually have to give in to the craving, and that the urge to take the substance and the action to take the substance are dissociable. And if at any point the patient becomes overwhelmed, they can always return the focus of their attention back to the breath as a way to recenter themselves. But we're not telling people to not take drugs. We're not moralizing to people. So ultimately, the last step is to proceed with intention. So if the patient does choose to take the drug, then do it mindfully. Recognize that you're putting a powerful chemical in your brain and your body, and that act has consequences. And so you should give it attention and respect and awareness. But for example, we have another variant of this technique for patients who are receiving medication-assisted treatment. So to practice this technique right before they take their methadone dose or their Suboxone, and to use this time not to stop themselves from taking this medication, but rather to use the time to reflect that this is the opportunity to help the self, to recommit yourself to recovery, and to be aware that you're taking this life-saving medication, and to have some gratitude towards it. So that's the stop technique. But we teach a different technique to help patients to cope with pain and craving. So people with chronic pain typically experience pain as this monolithic, solid, and unremitting experience. It's this terrible, awful thing that always seems to be there. And on top of that, they overlay a layer of suffering. They say to themselves, why me? This isn't fair. This pain is ruining my life. And this emotional anguish actually amplifies nociceptive processing in the brain. But in more, we teach patients mindfulness skills to remove this emotional overlay and then to deconstruct the pain experience into its subcomponent sensations. So rather than focusing on some terrible, awful anguish in the body, we teach patients mindfulness skills to zoom into the pain and to break it down into sensations of heat or tightness or tingling, as well as to notice the spaces in between those sensations where there's either no sensation at all or potentially pleasant sensations right next to the painful ones. And using mindfulness to cultivate interoceptive awareness of pain may actually reduce emotional bias during pain perception and thereby decrease the intensity of pain. But we use a parallel technique in helping patients to cope with craving, teaching them to use mindfulness to break the craving down into its cognitive, emotional, and sensory components, and then to observe the arising and ceasing of those experiences from the state of meta-awareness. Okay, so now I want to talk about one of the techniques in more that makes this therapy quite unique. So in more, patients are taught a mindful savoring technique, which is depicted here in this infographic that was designed by the National Center for Complementary and Integrative Health for the MORE research program. So in session 4 of the MORE intervention, we bring patients in and we ask them to practice savoring by focusing mindful attention on a beautiful flower, like a rose. Patients are guided to focus mindfully on the beautiful colors, the textures, the scent of the flower, as well as the touch of the petals against the skin. And during this practice, patients are guided to cultivate a metacognitive, reflective attitude, to become aware of the arising of positive emotions in the mind or pleasant sensations arising in the body, and then to turn attention inward and actually savor and amplify the positive inner feeling. Then they're asked to practice this technique at home with other naturally occurring pleasant experiences. And this technique is intended to amplify natural reward processing in the brain, boost positive emotions, elicit meaning in life, and cultivate experiences of self-transcendence, the sense of interconnectedness between the self and the world. So through this integration of mindfulness, reappraisal, and savoring practices, MORE aims to modify associative learning mechanisms that have become hijacked during the allostatic process of addiction by strengthening top-down cognitive control functions to restructure bottom-up reward learning from valuing drugs back to valuing natural, healthy rewards. And that approach is in line with what I call my restructuring reward hypothesis, which is pretty simple. It just says, if you can help the patient to shift from valuing the drug back to valuing natural, healthy reward, this will reduce craving and addictive behavior. And in my view, not only as an addiction scientist, but also as a psychotherapist who's worked with patients with substance use disorders for about 2 decades, I think this therapeutic process of restructuring reward learning is the essential therapeutic process in addiction recovery. The person in recovery must relearn what is and what is not important in life, what is and what is not meaningful in life. They need to reclaim that sense of meaning that had been stolen by the drug and then reinvest it back into the people, the activities, and the values that they once cared about. So this is an overarching therapeutic principle in the MORE intervention, but we teach concrete techniques to help patients to do this. Okay, so I've laid out a bunch of theory for you about MORE, but let's get into the data. So MORE is an evidence-based therapy. To date, MORE's been studied in 13 randomized controlled trials involving more than 1,300 patients. And there's enough data now to start to do meta-analyses about MORE. So a recent meta-analysis was published and found that MORE produced statistically significant effects on reducing addictive behaviors, psychiatric symptoms, and chronic pain relative to a wide range of active control conditions. So I just want to highlight a few of these studies for you here today. The first is the first NIH-funded stage 2 randomized controlled trial of MORE as a treatment for chronic pain and opioid misuse. In this study, there were 115 chronic pain patients. They had been taking opioids for about 10 years. They were randomized to receive 8 weeks of MORE or 8 weeks of a supportive psychotherapy control condition. At the beginning of the study, 3/4 of the sample reported misusing opioids, and there were high rates of comorbid psychopathology in this sample as well. In summary of the findings, MORE led to significantly greater reductions in chronic pain severity and pain-related functional interference than the supportive psychotherapy control group. And coming back to our model here of how we think this pain relief is happening, we found that the effect of MORE on alleviating chronic pain severity was statistically mediated by the capacity to reinterpret pain not as pain, but rather to see that pain as harmless sensory information. So we asked patients, to what extent do you view your pain not as pain, but rather as sensations of warmth or tightness or numbness? And the more patients were able to do that, the greater the pain relief they achieved. And I always like to replicate my work. So we in fact have replicated this pattern in a number of studies. Here's data from another randomized controlled trial showing that the effect of MORE on reducing chronic pain severity is mediated by this capacity to reinterpret pain as harmless sensory information. And in this study, we also found that MORE reduced opioid misuse. There was a 63% reduction in opioid misuse in the MORE group, compared to a 32% decrease in opioid misuse in the supportive psychotherapy control group. And I would point out here that our control condition was an active treatment. You can see it was helping to reduce opioid misuse, but MORE was mo better. Sorry for the bad dad joke. My kids would be groaning right now. And in this study, we used the DOT-probe task to measure hedonic dysregulation and MORE's effects on that. And we found the first evidence in the scientific literature from a randomized controlled trial that a mindfulness-based therapy could reduce the pain attentional bias. So after 8 weeks of training with MORE, patients' attention was less hyperfixated on, was less captured by pain-related information. We also found that MORE significantly reduced the opioid attentional bias. And we recently replicated these results in a much larger sample. Same thing. After 8 weeks of treatment with MORE, patients' attention was less captured by the opioid-related cue. And you can think of this task as an objective way of measuring to what extent the patient is being triggered. It's a laboratory measure of being triggered by addiction cues. And we're seeing here that 8 weeks of MORE significantly reduced the extent to which the patient was being triggered. But some of the most interesting data from this study came from heart rate collected during the DOT-probe task. And I don't think you really need to know any statistics at all to see there's a big effect happening here. We found that across all 3 cue conditions of the DOT-probe test, that MORE led to significantly greater reductions in heart rate during this task. Not surprisingly, the more patients' heart rate slowed as they viewed the opioid images and the pain images, the less aroused, the less stimulated, the less triggered they felt by those images. And that made perfect sense. But we found the opposite pattern in response to the pleasurable photographs. The more patients' heart rate slowed as they viewed the pleasurable photographs, the more aroused, the more stimulated they felt by these images. And so we took this to mean that maybe more was increasing physiological responsiveness to natural pleasure. We conducted a heart rate variability analysis and found that across the entire task, more led to significantly greater increases in heart rate variability, but the effect was most pronounced to the pleasure cue condition. So for the clinicians in this room, you're probably wondering, who cares? What does this heart rate stuff have to do with actually helping people? So to answer that question, we conducted a multivariate path analysis and found that the effect of more on reducing opioid craving was statistically mediated by changing the heart rate response to the pleasure cue condition. So in other words, more was reducing opioid craving by enhancing physiological responsiveness to natural, healthy pleasure. And that represented the most significant scientific finding of my career up to this point. And I think you can appreciate this if you recall that the prevailing neuroscientific model of addiction, neuroscience, the allostatic model, states that as a person becomes more and more addicted, they become less sensitive to natural, healthy pleasure, and this drives them to take higher and higher doses of the drug just to feel okay. But these data suggest that that process might actually be reversed. That by teaching people to become more sensitive to natural, healthy pleasure, this might reduce addictive behavior. So it was this finding that really let me crystallize my restructuring reward hypothesis. And I think it also was a big deal for the field and probably played a big part in the subsequent funding of about $25 million worth of research grants. So in this study, we also collected ecological momentary assessments. So we asked patients to rate their pain and their mood state every time they took their opioid medication up to 4 times a day over the course of treatment. So this gave you a tremendous amount of data, 224 time points per individual. And we found that more was decreasing pain intensity from moment to moment in everyday life. We also found that more was increasing positive emotions from moment to moment in everyday life. In fact, patients in more had 2.75 times the odds of patients in the control group to be positively emotionally regulated over the course of treatment. What does that mean? That means that if I'm in a bad mood in this moment, in the next moment, I'm able to improve my mood. Or if I'm feeling good in this moment, I'm able to preserve that positive mood in the next moment. Patients in more had 2.75 times the odds of those in standard supportive therapy to be positively emotionally regulated. But interestingly, it wasn't the decrease in pain that predicted reduced opioid misuse, but rather patients who showed the largest increases in momentary positive emotions throughout their day reported the greatest decreases in opioid misuse. And that provided some additional support for my restructuring reward hypothesis. This idea that if you can teach people how to make themselves feel good naturally, they won't need the drug. Okay, so let's take stock in an interim summary here. What do we know? We know that more seems to decrease addictive behavior, craving, and drug cue reactivity. And more also appears to decrease pain. And at the same time, there are some promising effects on more and increasing positive emotions and natural reward processing. So my next step was to replicate these results in a second stage 2 randomized controlled trial. We conducted this study in the primary care environment. And once again, we found that more led to significantly greater reductions in chronic pain and significantly greater reductions in opioid misuse than supportive psychotherapy. But in this study, we also measured an array of positive psychological functions, including positive emotions, savoring, meaning in life, and self-transcendence, the sense of being connected to something greater than the self. And importantly, the effect of more on reducing pain, severity, and opioid misuse was statistically linked with increases in these positive psychological functions, suggesting that one way to treat the disease of despair is to teach people how to savor natural, healthy pleasure, joy, meaning, and self-transcendence. So around the same time, we started wondering, well, would more be useful for patients with full-blown opioid use disorder who were addicted to heroin and fentanyl and street opioids? So my colleague Nina Cooperman and I got an NIH grant to conduct a pilot RCT of adding more to methadone treatment. So we conducted this study in inner city New Brunswick, New Jersey, in a predominantly African-American and Latinx sample. It was a small pilot, only 30 patients. We didn't expect to see a significant effect, but we did. We saw that more led to significantly fewer days of opioid use, significantly fewer days of drug use in general, less chronic pain and depression than methadone treatment as usual. In this study, we also collected ecological momentary assessments by smartphones, and we found that more decreased the intensity of opioid craving by 50%. More also increased positive emotions from moment to moment in everyday life. And once again, patients who had greater increases in positive emotions reported the largest decreases in craving, providing additional support for the restructuring reward hypothesis. So then we replicated this work in a larger NIH-funded randomized controlled trial. And this study started really at when COVID-19 was just ferocious. So we had to pivot to telehealth, delivering more by telehealth. So we gave data-enabled tablets to the patients and used HIPAA compliant Zoom and delivered more online for these folks in the community in New Jersey. And once again, we found that more was efficacious. So patients who received more had a 42% less chance of relapsing back to drug use than patients in methadone treatment as usual. Adding more to methadone treatment also resulted in 59% less dropout from addictions treatment. Patients in more had fewer days of opioid use and drug use than those in addictions treatment as usual, and more improved methadone adherence. So we recently published these results in the top journal, JAMA Psychiatry, and we're really encouraged that it appears that more is an efficacious treatment for opioid use disorder, and that if you combine it with standard addictions treatment, it just improves outcomes. So given all these compelling clinical findings, we wanted to kind of get under the hood and start to understand what was happening in the brain to produce some of these effects. So in another study, we brought in a sample of chronic opioid users into the laboratory and showed them opioid images on a computer screen while we measured their brain activity with EEG. And here in the red line, you can see the brain's response to viewing opioid cues before treatment with more. And here in the blue line, you can see the brain's response to viewing opioid cues after treatment with more. And these gray lines represent the brain's response to a neutral cue, like a picture of a napkin or a table or something like that. So you can see that more is in effect making the opioid cue more neutral. And all the way in the right, these are brainwaves from patients undergoing standard supportive group therapy. You can see that doesn't do very much at all. And if you have trouble reading the EEG, here's a bar chart that shows the effect. So a massive decrease in brain drug cue reactivity occasioned by more. So these are the first data in the scientific literature from a randomized controlled trial showing that a mindfulness-based intervention can reduce drug cue reactivity in the brain. So given the novelty and significance of these findings, they were published in the top journal Science Advances a couple of years ago. In terms of understanding more of Moore's mechanisms of action, using the emotion regulation task, we found that Moore significantly increases reappraisal efficacy as measured by skin conductance responses. And the effect of Moore on reducing emotional distress is statistically mediated by increases in reappraisal. But we've also shown that Moore increases brain and body responses to natural healthy rewards. So in a separate randomized controlled study, we found that Moore increased the late positive potential of the EEG and skin conductance responses during viewing and savoring of natural reward images. We also found that Moore increased positive emotions in response to these images. So we showed patients images of smiling babies, lovers holding hands, beautiful sunsets, and patients, after they were treated with Moore, they just felt happier when they viewed those images. And the effect of Moore on reducing opioid misuse was statistically mediated by increases in this natural reward responsiveness, providing what I think is really strong support to the restructuring reward hypothesis. And so I've got some new data here that this hasn't been published yet, but I'm going to work on that this year. You remember I showed you this graph showing that people with opioid use disorder have this blunting of brain response during positive emotion regulation. Well, in this sample of patients who are showing this blunting, they went through more or supportive psychotherapy. We gave them the same task again, and what we found was that more is remediating the deficit. Okay, so let's take stock again. What do we know? We see that more seems to decrease addictive behavior, craving, and drug cue reactivity. And at the same time, more appears to decrease pain. But more also appears to increase positive emotions, natural reward, and the sense of meaning in life. And so this brings me to the largest randomized controlled trial of more ever conducted. This was a $2.8 million grant funded by the National Institute on Drug Abuse, NIDA. In this study, there were 250 chronic pain patients, all of whom were prescribed opioids and all of whom were misusing opioids at the beginning of the study. They were randomized to receive 8 weeks of more or 8 weeks of a standard group supportive psychotherapy control condition. Patients reported pain levels on average of 5.5 out of 10. They had been in pain for about 15 years. They were taking high opioid doses at baseline, about 100 morphine milligram equivalents a day. 3/4 of the sample reported 2 or more chronic pain conditions, and there were high rates of comorbid psychopathology in the sample. So about 70% met criteria for major depression, 62% had a full-blown opioid use disorder, 21% had a non-opioid substance use disorder, and there were high rates of generalized anxiety and PTSD as well. And we delivered the study interventions in the primary care clinics, in the same offices where patients were receiving their opioid pain management. So in summary, the findings, more reduced opioid misuse by 45% at the 9-month follow-up point, nearly tripling the effect of standard group psychotherapy. More also significantly reduced opioid use and significantly decreased opioid craving. So I think these data really clearly demonstrate that more is an efficacious treatment for the comorbidity of chronic pain and opioid misuse. And we also found effects of more on chronic pain symptoms. So more significantly decreased pain-related functional interference, chronic pain severity, and at the same time, more reduced emotional distress. 50% of patients and more achieved clinically significant reductions in pain. And the effect sizes that we saw in this study exceed the effect sizes that are typically observed for the current gold standard psychological treatment for chronic pain, cognitive behavioral therapy. But in this study, we also showed that more improved an array of psychiatric symptoms. So more had robust antidepressant effects. Recall that at the beginning of the study, about 70% of patients met criteria for major depression. But by 9 months after the end of being treated with more, patients' depression symptom severity score no longer surpassed validated cut point for depression. More had powerful effects on reducing PTSD symptoms. We published those data in Nature Mental Health last year. 59% of patients who met criteria for PTSD showed significant reductions, clinically significant reductions in PTSD symptoms. And that was pretty amazing because we don't do any sort of direct processing of trauma in the more intervention, but just learning this ensemble of mind-body skills seems to be therapeutic for PTSD symptoms anyway. And we found that more improved positive emotions, meaning in life, and self-transcendence. So again, I like to replicate my work. So we actually replicated that trial in a study funded by the US Department of Defense in 230 veterans and military personnel on long-term opioid therapy for chronic pain. And once again, through an 8-month follow-up, we found that more outperformed supportive group psychotherapy in reducing chronic pain symptoms and reducing opioid use. It was an average of a 21% reduction in opioid dose occasioned by more. We also found that patients treated with more had a significantly lower rate of having positive drug urine screens, and more improved opioid craving, pain catastrophizing, and anhedonia. So I think across these two large trials, there's some replicability here. We can see that more is really an efficacious treatment, not only for reducing chronic pain, but also for reducing opioid use. But we've shown other really interesting effects. And so this is a computerized body map. And on this body map, patients locate pleasant and unpleasant sensations. Pleasant sensations are represented in blue. Unpleasant sensations are represented in red. And this is a one-sided body map, so it represents the summation of sensations on the front and the back of the body. And I think you can clearly see here that more is massively increasing pleasant sensations in the body and powerfully shifting the ratio of pleasant to unpleasant sensations. So at the beginning of the study, patients reported about 1 pleasant sensation for every 4 unpleasant sensations. And I just find that really sad. I mean, it speaks to how much these folks were suffering. But by 6 months after being treated with more, patients reported 2 pleasant sensations for every 1 unpleasant sensation, showing that more teaches patients how to internally self-generate natural, healthy reward responses and thereby shift the body from being a place of anguish to becoming a place of refuge. And finally, we were wondering whether the self-transcendent states of consciousness produced during mindfulness meditation might have any anti-addictive properties. So we brought patients into the lab. This was from my DoD study, the veterans. We brought them into the lab and we had them practice mindfulness meditation while we recorded their brain activity with EEG. And we found that more really powerfully increased frontal midline theta EEG activity in the brain. So it boosted theta oscillations in medial prefrontal brain regions. And the deeper the states of self-transcendence that the patient achieved during meditation, the stronger the theta. And the effect of more on reducing opioid use was statistically mediated by this increase in frontal midline theta power. So frontal midline theta is a well-known biomarker of cognitive control, but it also increases during states of flow, when the sense of self is temporarily suspended and transcended during deep cognitive absorption with ongoing experience. So these data suggest that mindfulness meditation may provide a means of endogenous theta stimulation, self-stimulation, and thereby enhance self-control over addictive behavior. But again, I always like to replicate my work. And so we conducted a replication in the largest neuroscientific study of mindfulness as a treatment for addiction ever conducted. So in this study, there were 165 chronic opioid users. They were randomized to more or supportive psychotherapy. We brought them into the lab. We had them practice mindfulness meditation, and we recorded their brain activity with EEG. And I love data like this because you don't need any statistics at all, right? So here's the game. Which one of these 4 is not like the other? This is your brain on more. Remember that old commercial? Some of you who are as old as me or older. This is your brain on drugs with the egg sizzling in the pan. You know, this is your brain on more. A massive increase in frontal midline theta EEG activity during meditation. And once again, the deeper the states of self-transcendence that the patient achieved during meditation, the stronger the theta. And the effect of more on reducing opioid misuse was statistically mediated by this increase in frontal midline theta power. So now we have 2 independent randomized controlled trials showing the same mechanism, same pattern. So I think this speaks to the fact that we may have indeed identified an important mechanism by which mindfulness reduces addictive behavior. And relatedly, if self-transcendence is not just an epiphenomenon, but is actually helping to drive some of the neural changes that are therapeutic in the treatment of addiction, then I'm starting to wonder, maybe if we combine more with psychedelic-assisted psychotherapy, if we could actually magnify this effect. So I recently completed a pilot RCT of more plus ketamine, psychedelic doses of IM ketamine versus more alone. And in fact, we did find that adding ketamine to more resulted in significantly fewer days of drug use. But also intriguingly, and this was a small study, but intriguingly, in the sample of patients who got the ketamine, the deeper the mystical states they achieved during the ketamine experience, that predicted less drug use in the future. So we might be onto something here. Okay, so in summary, now I think we clearly see that more significantly decreases addictive behavior and craving. At the same time, more is efficacious for reducing physical pain and emotional pain. But more also boosts positive emotions, the sense of reward and meaning in life. And these therapeutic effects are linked with increases in self-regulatory capacity, as well as self-transcendent experiences. So taken together, this body of work supports my restructuring reward hypothesis, which states that increasing natural healthy pleasure, joy, meaning, and transcendence may come to outweigh the pull of drug-related reward and thereby reduce addictive behavior. So I was at dinner last night with some wonderful company, friends from the Osher Center, and they asked me about what's next in my research. So one direction is to go deep into mechanistic science and really start to understand what are the neural mechanisms that are driving these effects. So there are a number of fMRI studies underway, and actually even a dopaminergic PET study underway to try to test what is more doing in the brain to alleviate pain and addiction. Another direction is in the total opposite translational direction. So try to take this work into the real world and start to understand how can we implement this evidence-based therapy in healthcare to actually help people. So we have a few R01 grants to add more to methadone treatment in the community to see if we can teach community-based addiction treatment providers to deliver this therapy with a high degree of effectiveness in the real world. And then we're doing another study of more. We're about to start where we're going to be delivering more as an insurance reimbursable medical group visit that I know Erin is doing that here now, which is super exciting. So to see, can we deliver this in primary care and help the patients struggling with pain and opioid use and do it in a way that is economically sustainable. And all of that implementation research does involve cost effectiveness analyses. And so there was actually a cost effectiveness analysis on my JAMA internal medicine study, the primary care study. And the health economists found that for every dollar spent on more, there are $798 in estimated cost savings. And so if you compound that over the lifetime of the patient, it's estimated to be at $320,000 in cost savings per person, which is pretty significant. So I'm trying to actually make my work count and make it actually do some good. And so as Erin said, this spring I was in DC. I got to present my work to the Addiction Recovery Caucus of the Congress on Capitol Hill, and that was a great honor. And so I'm really trying to work to influence policy. And federal policymakers, that's obviously important, but I think working at the state levels is probably even more important because that's where decisions are really getting made about how to spend dollars and influence care. So what I'd like to do is just to see more spread broadly, because I've spent 15 years developing and testing this thing. So now I want people to use it. So in conclusion, more is an efficacious treatment for addiction, stress, and chronic pain, as demonstrated by 13 randomized controlled trials. We've learned a lot about More's mechanisms of action over the past 10 years. More works by reducing drug cue reactivity, enhancing natural reward processing, boosting self-regulation, and eliciting self-transcendent experiences. And so now that I've done all this testing, I think it's time to disseminate the therapy. So I'm really dedicated to that. That's part of the reason why I'm standing here in front of you all. And I've been training clinicians from around the US and internationally. So to date, more than 950 clinicians, including social workers, psychologists, nurses, physicians, physical therapists. I even trained a chaplain earlier this week, have been trained in More and are now delivering it in clinical practice to help their patients. I think it's now time to optimize More. More's obviously, it seems to be a pretty helpful treatment, but it doesn't help everybody. So how can we combine it with other evidence-based therapies, including integrative health interventions with great evidence like acupuncture, or neuroscience-informed therapeutics like neuromodulation, neurostimulation, psychedelics? How can we make it better? But ultimately, teaching people to take in the good and mindfully savor natural, healthy pleasure may provide the learning signal needed to restore adaptive hedonic regulation and ultimately to reverse addiction. And I know that's a bold claim, but we're facing a serious crisis in this country. So I sincerely hope my work is helping in that regard. So I thank you for your attention. I want to thank the funders of my work. If you're interested, I'm holding a more training in November by Zoom. There's still a few seats left, so if you want to get trained, come to the training. But thank you for your attention and happy to take your questions.
Thank you very much, Dr. Garland, for a wonderful talk and great data. We have plenty of time for questions. If folks want to raise their hands, I'll run. Harold.
We can hear. Thanks for a good talk. One minute. Oh, and just thinking about patient. Life, how things are going to change. That internal shift, even if I can't. It makes me wonder. Provide this to folks having even a possibility of addiction.
Yeah. I'm doing Department of Defense surgery. So we're giving them just one more session of mindfulness. So it's really kind of like a stepped care dosing model, which I think is a pretty exciting study. And we're way behind in enrollment, but we've got about 230 people in the trial already. So should be able to get some answer. But I like your thought process there. What if we gave it to people before they were prescribed opioids? Could we prevent this problem to begin with?
I don't know.
Okay. Pretend it's work.
You can try to repeat the question, but we'll do our best.
Okay.
Thanks for the amazing talk and work research. I have lots of questions, but I wonder if you would tell us a little about kind of the origin story, how you found more, discovered, and if you have time to also say what is it like for people, just like what people say, how do they express the changes that scientifically got?
Yeah, I should have included a couple of clips because I do have that in a different talk. So the question was, what's the origin story of more? And like I said last night at dinner, that's the story of my life, basically. And I don't want to bore you with the story of my life right now. But I mean, in brief, more came out of my personal practice of mindfulness as a spiritual practice. I started that way. And I recognized just how powerful of a healing force mindfulness was in my own life. And that really inspired me to become a psychotherapist. So I started doing clinical work before I was a scientist and working in integrated medicine settings which I think is a nice setting. It's distinct from the mental health field, right? Because you're not only dealing with the patient's mental health issues, but you're also dealing with their medical issues, physical pain, et cetera. And of course, all these things come together. We have different specialties, but patients don't have specialties, right? Patients bring the whole problem with them. So in my clinical work in that setting, this was in the early 2000s when mindfulness was not what it is today in healthcare. And there weren't really very many models of mindfulness-based psychotherapy, or if there were, I didn't know about them. So I just started making it up. I just was winging it in my practice, integrating my own personal experience with meditation, with cognitive behavioral therapy. And that's really where more came from. I guess that's the short origin story. There's the longer synchronicity laden version of the story, but that I'll tell you over a beer. Oh yeah, I wish I have a bunch of clips of patients talking. I mean, what do they say about how it impacts their life? They say all kinds of amazing things. I mean, I think one of the profound things that patients say, or one of the things that is profound to me. So I spend a lot of my time listening to tapes of therapists do this therapy, and then supervising the therapists to make them better. So I get to hear a lot of these reports. And one of the things that always amazes me, in the middle of the group, the therapist is teaching mindfulness, and then they're debriefing the mindfulness, and the patient is saying, yeah, I feel so relaxed, I feel so comfortable, I feel so peaceful. And then we train over the years, we've developed a tactic around this. And so we train the therapist in that moment to say, well, I'm just curious, when you were feeling that sense of relaxation and peace, what was your experience of pain like in that moment? And I can't tell you how many times I've heard this, countless number of times. These are people whose average pain level is an 8 out of 10, for the past 10 years, right? And you say, I'm just curious, what was your pain like in that moment? And they go, pain? Pain? Oh yeah, my pain. Now that you mention it, I guess I didn't really notice my pain. And that's, to me, they always say it in a nonchalant way. They're never impressed, by the way, when that happens. It's like, I didn't notice my pain. But we get impressed, we train the therapist to say, wow, wait a second. You mean you were able to use mindfulness to completely alleviate your pain in that moment? And that's a real light bulb moment for folks. So that's one thing that comes to mind. But people obviously report benefits that go beyond pain, more holistic benefits in terms of their relationships with their family, their ability to work, and just appreciating beauty in life. So those are the kind of things that we hear.
Find that people are pretty motivated to stick to it, and that how long?
Great question. So everything that I know about this, you got to take it with a grain of salt, because I'm doing research studies where I'm paying people. So where the rubber meets the road is when this goes out into the real world. People like you guys start doing it in your clinics, and then how are people going to show up? Are they going to pay their co-pays? So by and large, in the trials that we've done, we get a pretty good adherence completion rate, somewhere like 75% to 80% of folks are getting at least 4 out of the 8 more sessions. But that takes a lot of herding cats to make that happen. And in terms of adhering to the practice, I've done a really poor job of collecting data on that, actually, because I just massively bombard my folks with asking them a million questions over and over again. But I think when you look, I'm doing this because I want to show you, when you look at the data, for example, for our longest follow-up that we've done so far, you can see that the effect is it's actually getting stronger over time. It's not fading away. I mean, this is the end of the 8-week treatment, but look, it actually keeps getting better. So my hunch is that's because people continue to practice. But we haven't done a good job of asking them to quantify their practice in the long term. We've collected a lot of practice data in this period here using smartphones. How many minutes a day do you do each practice? And not surprisingly, the more people practice, the better the effect. But yeah, so I don't know. We need to do more research to figure out how long will people the skills? What can we do to help them encourage their practice? And I have some ideas about that. But yeah, it's tough. It's like any other health behavior, you know. Who adheres to a diet? Who adheres to an exercise nutrition plan? But that's why I think this is not just a self-help thing. You know, this is something that you're doing with a very skilled therapist, very skilled professional. So those sessions really, I think, count. Those can be powerfully impactful healing experiences that may have some sustained effect, even if the person isn't practicing a lot outside of the sessions.
All right, our time is up. Thank you again for a wonderful talk, and great hearing about your work, and enjoy the rest of the day.
Thank you so much.